Do you find with antihistamines, even with things like Claritin, the thought of developing like a resistance to the treatment comes to mind? Is that something that patients often have to worry about, and how do you deal with that?
It's not necessarily resistance. It's just that they're not totally effective.
Hmm.
They tend to work to some degree in some people better than others, but it really is variable. So
Hmm.
you don't know until you try.
Hmm.
And like I said, you push the dose of the H1 blockers, the non-sedating blockers, and then you add H2, and then you may go to a drug like xolair. And then we can talk about other drugs that are coming out also
Yeah.
that are helpful.
Yeah, I definitely want to get to those other ones too. What are your strategies though for managing patients who don't respond to high dose antihistamines? Is that common, for instance, and is there a particular group or kind of presentation that that's impacted more by?
It's not a predictable response. So basically, you have to try it. You always try that antihistamine approach, unless you knew for sure that it was a type 2B autoimmune type of urticaria, which you wouldn't necessarily know. But basically, you always push the antihistamine dosing as much as you can, and then you need to go to other levels of care.
Mm. Could you discuss the current and emerging roles of biologic therapies, like some of the ones that you've discussed, and just kind of go into what your opinions are on some of those
Absolutely.
approaches?
So our approach was what we call downstream blockage. We were blocking at the H1 level, at the cellular level, the effects of histamine. We were trying to block that effect. Now we're trying to we're going upstream, so to speak. So we're blocking IgE, that's Xolair. We're also finding that there are enzymes that form cascades that actually, if we can stop those processes, the mast cells are not allowed to degranulate and send out the histamine. So if we can block intracellularly or at the receptor level, that's a better way to treat this disease.
Mm.
So what we found is that there's something called Burton tyrosine kinase, and if we can block that enzyme, we find that there is a reduction in the degranulation of the mast cell. So histamine is not released. So we find that's a very effective way of doing it. There's also another receptor that we're targeting. It's called a KIT receptor. It's on the cell, it's on the mast cell. And if we can block that at that level, the mast cells don't survive as well. And we're finding that we're reducing mast cell uh, degradation. I mean, not degradation, but release of histamine as a result, because there are less mast cells and they're less effective.
Mm. When you consider cyclosporin or other immunomodulators, how do you monitor safety in those scenarios?
Well, truthfully, I stay away from cyclosporin. It was a therapy that we used in the past, but now that we have these newer drugs that are available to us, there's really no need to use cyclosporin. But cyclosporin is basically a general immunosuppressant. It really works on the T cells, which secondarily work on the B cells, which secondarily work on mast cells. So it's a really indirect effect. But cyclosporin can cause hypertension. It can cause abnormal hair growth. It can cause kidney disease. So it's a drug that I avoid
Hmm.
in
What are the
particular.
common side effects for either therapy route that we've discussed so far? And are there any that you consider kind of a real, um, that have real quality of life impact that you have to talk to patients about particularly?
Actually, the drugs I mentioned, like Xolair and the KIT receptor inhibitor and the BTK, they're pretty safe for what they do. We're finding there are some side effects, but they're really tolerable side effects.
Mhm. Interesting. Tell me a little bit, what are some common misconceptions that you find with patients about triggers or allergies and chronic hives, and how do you address them?
Well, triggers are things like bee stings or venom exposure, foods in some cases, or environmental exposures, air exposures if you're allergic. So, yes, there's an allergic component to all of this.
Mm.
And of course, the immune system gets stimulated as a result. So if we can define what's causing those causes of urticaria, then obviously we eliminate them.
Mm.
So it's an elimination diet, for instance, if it's a food item. But in chronic spontaneous urticaria, we find that that's more of an autoallergy or an autoimmune condition. It's not necessarily related to something external.
Mhm. How do you integrate patient-reported outcomes tools like urticaria activity score into management or follow-up decisions?
I think those scores are important because you're interviewing the patient and determining how often are you getting their hives, how's it affecting your quality of life, so, and how much itch do you have? It gives us a basis of how they're doing now, and how they're doing during therapy if you institute therapy. So those scores are very important, particularly in research.
Mhm.